We've got a few questions on the app, and carrying on completely seamlessly from your last comments, Rachel. Question here: is the risk appetite of the patient considered? There may be cases where there is a higher risk reward scenario.
Is the risk of what, sorry, considered?
I think the question is, about the level of risk the patient is prepared to accept.
Yeah, absolutely. And it's an extremely individual conversation, and everyone in this room will have different thresholds for accepting risk, not just in their healthcare, but other aspects of their life, and priorities in terms of their family circumstances, the level of care they'll need after surgery, whether they'll return to independent living. These are all critical issues that you discuss in quite a brief clinic consultation, at each step of the process. And I think there's, the message from today is that there's an individualized patient pathway for every person, and that there's no right answer, I think.
Yeah, I agree. I think from experience, I would say it would be unusual for a patient who is fit for surgery and is operable to decline surgery. It's just not certainly in the south of England, that isn't our experience. They, generally speaking, would go for it. And most commonly, we find patients are more keen to go for it than maybe we are. It depends ultimately on the fitness of the patient. I mean, I think we can say honestly we have very low mortalities in the averagely fit patient doing even perihilar carcinoma surgery, but it is an individual decision.
Another question here: is any technology being developed that could improve outcomes for surgery or make surgery more possible?
Well, let me go first. I mean, I think we obviously are entirely comfortable now with neoadjuvant chemotherapy in colorectal liver metastasis, and it's almost so routine that pretty much everybody, it's hard to stop oncologists giving it now. And the same would apply to breast cancer, which I don't practice in. Now, we have tried occasionally to do neoadjuvant therapy in perihilar cholangiocarcinoma, and it has not always gone well. We've managed to do it with a reasonable effect in patients who come not jaundiced. For the jaundiced ones, the last one we tried, we just couldn't get it to work. It was just the sepsis was a problem, and so that's difficult. So unless somebody can come up with a magic way of enabling us to do that safely, I don't really see that.
Okay. The other thing that I think will be interesting to look at over the coming years is CERT, and the data probably are not there yet, but when we've looked back at CERT patients, there will be people who've come into resectability criteria following CERT, and I think we just need more numbers published to know whether that may be a downstaging local regional therapy.
Yeah, I think it's quite interesting, CERT. I mean, we're allowed to use it for HCC where there's no data to suggest it works, and we are not allowed to use it for cholangiocarcinoma where there's at least some data that it works. I really don't understand this. We have accidentally treated some patients thinking it's HCC, and it's turned out to be cholangiocarcinoma, and it's done quite well.
Julien's giving a talk on CERT later. Do you want to comment now or later? Later. All right. Wise. Okay. There's no role for AI in sort of surgical resections. Similar to what's being done in colonoscopy.
Well, AI? You mean something that's better than us?
Better eyes than the surgeon.
Yeah.
Okay.
We'll see.
Let's move on.
That's the question there.
Yeah, thank you. Two excellent talks. I'm a hepatologist, so liver function's particularly important to me. There's not much data.
It's important to the patient as well, actually.
Yeah. There's not much data on all the resection stuff about the level of fibrosis or cirrhosis. Is that because patients who've got cirrhosis and perihilar cancer just don't even get to surgery? Or is that just because people, and if they do, is it just very few of them? Or if there's a decent number of them, presumably their outcome is particularly worse? But that nuanced thing doesn't seem to be there in the literature. Or maybe they're just not getting surgery.
Maybe you go first, Rachel. I've got a view.
Yeah, no, I mean, I think that's right, that these operations are high risk enough, particularly the extended hepatectomies, and if you have a liver dysfunction, underlying liver disease, transplantation is such a relatively new thing that it will be interesting looking at the outcomes of those patients. But, generally you've got to have pretty good, FLR of 40% is quite a push. So I think probably just the numbers are not there. And, these data are really plagued by publication bias. No one's going to publish poor outcomes. And we really need to get a better idea of the reality of what actually happens and not just the best studies.
Yeah, I was going to make a point about publication bias as well. And then just as a reflection on the question about what level of risk is the patient going to take, I often have this ethical debate with my medical students and say, well, if a patient is willing to accept 99.9% chance of mortality, should the surgeon and his or her team therefore go ahead and operate? And they sort of say, yeah, of course, right, it's up to the patient, right? And I said, you've got to look at it from the surgical team's point of view. You can't ask the surgical team and the anaesthetists and the nurses and everyone else to operate knowing that if they'll do 100 of these, they're going to kill 99 people, right? That's not sustainable as a medical professional to live with that level of mortality. So ultimately, that's why, sometimes people don't understand and say, well, if I'm willing to take the risk, what difference does it make to the medical team? And I think sometimes people forget that the medical team are also humans.
It is the case, as I said earlier, that in general terms, patients are prepared to take usually more risk than we are. I mean, I think the national statistic is about 8%, 90-per-day mortality. I think certainly with a South of England population, we certainly do better than that. But if you said to a patient it was 20%, 30%, a lot of them would actually say, well, what are my other options? And so I think we're often more likely to be dissuading a patient from having
another point as well is that when you're making these decisions and deciding whether am I going to take the risk of dying, a lot of these complications can be associated with significant suffering, post-hepatectomy liver failure with recurrent sepsis, very prolonged admissions. It's rare, but that is an extraordinarily challenging situation to find yourself as an individual and your family. And trying to counsel a patient who has never experienced or seen a person in that scenario is quite a difficult, getting truly informed consent in the outpatient clinic, I think is an extremely challenging thing for all of us to really manage.
There are several questions here. One is, could R1 resection speed up the disease progression? So if surgery is not radical, some tumor cells remain at the surgical margins, this can speed up the disease progression?
Well, I'm going to have an argument with Rachel now about the data she presented, which, as I interpret, was 0% 5-year survival with an R1. Yeah, that's what you said?
Well, no, not just R1. That was the benchmarking study. Yeah.
Right. So, all right. So I misunderstood you. I mean, what we know from Bill Cap is that R1s do worse, and nobody's going to dispute that. But they don't. Some of them actually get long-term survival for whatever reason, and I don't think we can entirely explain that. But presumably, it's a technical R1 in which there is sort of tumour up to the edge, but actually you've ultimately actually got all the disease out. We are limited in our ability to, I believe, to improve that. And I think this no-touch portal vein resection that the Berlin group have been doing for years is not an easy thing to do. And you've got to look at the trade-off, I think, of mortality related to the vascular resection, which I cannot believe is minimal compared to the risk of leaving tumour behind. So I'm not sure we've got any particularly good ideas. I think we can get the bile duct margin more likely to be tumour-free with hepatic venous deprivation to get a bigger remnant. You can take more bile duct. But ultimately, there's a point beyond which you cannot go because you're into the smaller biliary radicals, and that's it. No, you can't do any more than that.
I think the strongest evidence is that R1 resection increases your risk of local recurrence, not just in cholangio, but other tumour types. Does that increase your risk of metastatic disease? I don't think we really know that. I mean, assume...
Well, we do know it because that's what we publish in JCO, because there's more systemic disease in the R1s, and so they seem to be, I think they seem to be related, and it probably makes sense. You've got a worse local tumour, and it's just it's already metastasized.
Yeah.
So it makes sense. I think it makes sense.
There is another point very interesting, and I think very neglected, that is about mental health support. So the question is a bit articulated. Given the trauma of surgery, does the mental health of the patient impact the 5-year survival rate? And this is one point. But the other point that is, I think, really important is, does the panel feel that the mental health support is satisfactory?
No.
Probably not. I mean, we all have CN, clinical nurse specialists, and they're invaluable, but I think it is limited, and I think you can't, in this country, you can't really get mental health support in any setting, let alone the perioperative one. So the answer is no. It's not adequate.
Are the CNSs here to comment on that, please? Any CNS? There are some CNSs. What would you? Come to the mic, please. This is Polly Rogers from Princess Alexandra.
So yes, mental health is a big factor, I think, in the recovery and during treatment in general. How the patient views things, it plays a big part. And I actually have a question as well. It's regarding, I don't know if you use the term, but we've started hearing the term downstaging chemo, and I don't know what the difference is between downstaging chemo and neoadjuvant chemo, and how that would affect a patient's perspective and a patient's perspective on the treatment that they'd be receiving.
Well, I guess downstaging is when it works, and I don't think you ever downstage. You downsize. So I prefer the term neoadjuvant chemotherapy because it does what it says on the tin, really, and it doesn't imply that it's going to do any good. But it obviously does in colorectal very often. Biliary tract cancer, I think, is not just so easy.
I think we've also learnt the lessons from pancreas as well, that it's very difficult to judge preoperatively whether you have truly downstage someone. It's only once you've done the operation that you know whether it has worked or not. I think there is obviously aspirations, particularly in the targeted precision era, that we might have some therapies, and there have been patients have really dramatic response to targeted treatment, but this is absolutely, I think, for the future and not a current reality. But yeah, I agree the terminology is confusing for patients.
So it's a bit of a buzzword, really.
I think neoadjuvant therapy is a good term because that's what it is.
Thank you.
But just to finish off that point and to continue about what Rachel said, some of the new targeted agents, 88% response rate. Does that change your view about the concept of downsizing?
So, I mean, you're talking a principle about intrahepatic, I guess.
Intrahepatic.
Yeah. Rather than perihilar, which doesn't commonly have these sort of responses. Yes, I mean, it may well. It may well, but I think we would have to discuss how you went about doing a trial on that, and that's not going to be that easy.
Straightforward. Correct.
Not going to be easy.
Okay.
Okay. Are we done? Anybody else? Last chance to interrogate surgeons. They're a pretty rarefied species, even in this meeting. Excellent. Okay, thank you very much.
Thank you.
Very entertaining.